6. So good afternoon, everybody. And today we are going to discuss about a very important topic of lipid disorders in children. This is one topic which is becoming increasingly relevant given the increased awareness about these conditions and the increased diagnosis of lipid disorders. So we'll be talking about not only about the rarer forms of familial hyperlipidemia, we'll also talk a lot about what to do in terms of obesity and other chronic conditions, and how there has been a great change in terms of management of these conditions. So we'll start off with this discussion about lipid disorders. And of course, we have to start off with why we are talking about this topic. So as pediatricians, generally, we have not very commonly been trained with regards to the pediatric disorders and lipid profile and how we manage those conditions, and therefore often confusions happen. This was an 11-year-old boy who presented with obesity to us. And at that point of time, the evaluation was done, which showed that he was having a BMI of 1.8 standard deviation score. He had a normal blood glucose, and somebody did a workup which showed a cholesterol level of 190 and a LDL cholesterol of 140. We'll discuss about the various cutoffs and how to evaluate. Now, the nutshell, what happened was that this child was diagnosed as hyperlipidemia, and advised a treatment with statin. Now imagine starting an 11-year-old boy on statin and how long to treat, and this would probably be a lifelong therapy, is a major issue to concern. So what we'll discuss subsequently today is that the management of lipid profile in adults is now entirely cardiovascular risk based. We are not talking about numbers. Even in children, we are now talking about what is the cardiovascular risk, which in this case, if you see, comes into this obesity category. So this is an at-risk situation. And at this point of time, we don't need to really treat our LDL cholesterol of 140. So this clearly highlights the importance of not unnecessarily managing a condition like this. And this is what we're going to discuss about in detail subsequently. We have the second case, 11-year-old boy with xanthomas. This was a typical case of a familial hypercholesterolemia with tendon xanthomas, very high levels of cholesterol, high levels of LDL, started on statin, and now the child presented with the respiratory distress. So now this is something very, very important to understand, that individuals who have familial hypercholesterolemia are at a very high risk, particularly if their cholesterol is at a sky high level, of developing multiple complications, including early onset MI. But in this case, what we need to really understand is that supravalvular aortic stenosis is something which has to be excluded. And if our echo had been done at the right time, we would have really diagnosed this aortic stenosis earlier, and the syncope and all these problems could have been avoided. So therefore, a timely evaluation and management of these conditions is important. So if you now think of it, dyslipidemia is reasonably common with increasing prevalence of obesity. In our own data, we have around 30% who are actually having some form of dyslipidemia in obese children. If you talk about general population, maybe around 10% will be a good figure. Out of this, 99% are because of lifestyle, metabolic, all those factors, and only 1% have an underlying genetic cause. But these 1% will be extremely important from management because they will have the maximum cardiac risk. So we need to have a careful assessment and management of these disorders to achieve a successful outcome. So based upon this, we'll discuss about this in more detail. You can get more details about lipid disorders in our master course, which is there, which is around 85 modules, which are available online, and you can access that from there. We have got the MedEClasses app, which also has a lipid section coming up very soon, which will help assess the severity of lipid disorders to identify and treat accordingly with regards to the management pathway. So lipid disorders in children are uncommon, but one which require appropriate evaluation and management. So we'll start directly with pathophysiology because this is something which is often not covered in a pediatric training perspective, and this is extremely important. So if we talk about lipids, we are basically talking about two molecules. We're talking about cholesterol, which is responsible for the cardiac problem. We are talking about sterols, which are basically nothing else but plant cholesterol. So they just don't have this double bond at this carbon point. Otherwise, they are the same. Most sterols which comes from the plant is not absorbed. And therefore, it is actually used as therapy for hyperlipidemia, particularly with the use of things like margarine in that perspective. The second important lipid is, of course, the triacylglycerol or triglyceride, which is not a direct cardiovascular risk. It is associated with cardiac issues, but overall the triglyceride risk is more with pancreatitis rather than a cardiac defect. So when we talk about long-term cardiac risk, we are talking about LDL cholesterol. While we're talking about pancreatitis, we're talking about triglyceride elevation, and this is important to understand. From our clinical perspective, if we look in now in terms of the pathophysiology, so this just went off forward, the major role of cholesterol. So why do we need to have a lipid in the body? It is a readily available source of energy. It forms the steroid hormones in that perspective. It provides storage for energy in this situation and forms cell membrane. So without lipids, we will have a huge problem, and this is what we'll discuss in the setting of A-beta lipoproteinemia. When there is no cholesterol, it is very, very bad for the body. So while too much cholesterol is bad, even not having fat is also bad in that situation. So if we now think about the overall lipid cycle, we get the lipid from the intestine, it is absorbed, it provides energy to the heart, which is pumping to the muscles. Extra amount of lipids then goes to the adrenal to form the steroids. It provides deposition in the fat to provide energy for long term. Therein it goes to the liver, And from the liver, it is packaged back to the circulation where it can get deposited in the macrophage to the cardiac illness. So basically, if you think of it, there are three major parts of the body which are involved in lipid metabolism: the intestine, the liver, and very importantly, the circulation. So in this perspective, we'll start off with the dietary lipid pathway. We understand that the triglyceride and the lipids are absorbed largely by the smaller intestine once they have been digested from there. So they will have smaller molecules in the form of the fatty acids which are there, and they are absorbed in a micelle form. From there, this triglyceride is packed into chylomicron, and this chylomicron then goes in the blood circulation where it is acted upon by lipoprotein lipase. So this chylomicron has got 95% of triglyceride. It's a triglyceride rich compound. So all the lipids are packaged out here. From here, it is acted upon on the help of ApoC2, which is a part of the chylomicron. So these lipoproteins are basically big proteins which carry these lipids. They will contain triglyceride, they will contain cholesterol, they will contain cholesterol esters in differing amounts. So chylomicron is 95% triglyceride. It contains ApoC2, which is an apolipoprotein. So on top of them, they have a signaling molecules which will help them signal the pathway. This stimulates the lipoprotein lipase, which along with this GP1 HDL binding protein, which is a stimulant of lipoprotein lipase, allows the triglyceride to be released, which is then used by the heart and the muscle as discussed. Excess amount goes back to the adipocyte and also goes partly to the adrenal to produce some of those hormones. And this lipoprotein lipase therefore forms a very, very important part of triglyceride metabolism. Conditions associated with lipoprotein lipase deficiency, GP1-HB1 deficiency, or ApoC2 deficiency will be associated with familial hyperchylomicronemia, in which the triglyceride levels will be in thousands, and they will present with early onset recurrent pancreatitis. Now, once this triglyceride has been extracted, this chylomicron becomes small. It then goes to the liver and is taken up from there by the remnant receptor. So basically, there is a transfer of triglyceride to the circulation. The remaining lipid goes to the liver where it is internalized, and then liver will repackage this in that perspective. So we can think now chylomicron as the delivery vehicles. Let's say when we see so many of these gasoline vehicles, they're taking supply from the intestine, they supply the gasoline or let's say the triglyceride to the circulation, and whatever is left goes back to the bank, which is the liver. So the major supplier here is the intestine, and liver is pretty much the bank in that perspective. Now, once the liver produces some amount of lipid, it also gets lipids from all these lipoproteins, be it chylomicron, VLDL, LDL. So this whole lipid is then put back to the circulation. So what happens at the level of the liver is that this fatty acid, along with glycerol, which comes from the carbohydrate, lipoprotein, they all form and develop triglyceride. And this triglyceride is packaged with the help of MTP, which is a microsomal triglyceride transfer protein, into a lipoprotein known as VLDL, or a very low density lipoprotein. Now, if you look at it, chylomicron and VLDL are pretty similar. Chylomicron has got 95% triglyceride, VLDL has got 80% triglyceride. It has got Apo B-100, while chylomicron has got Apo B-48. And MTP is required for cholesterol or lipid transfer for both chylomicron as well as VLDL. Deficiency in MTP is associated with conditions known as A-beta lipoproteinemia, in which there is no production of VLDL, no production of chylomicron, so there will be a complete deficiency, so to speak, of cholesterol in that perspective. Now, this VLDL will then go into the circulation, and because they are large in amount, they can't go directly to the circulation. They will go to the lacteals, where they have additions of other apoproteins like C2, C3, and they become the mature LDL in that perspective. So the endogenous lipid pathway basically starts from the liver, where we have formation of the VLDL along with 80% triglyceride, 20% cholesterol goes into the blood. is again acted via the lipoprotein lipase, which basically takes off the triglyceride from here with the help of ApoC2. This smaller VLDL also loses some of its peripheral apoprotein, gets converted into what is known as the intermediate density lipoprotein. So now if you think of it, it may sound complicated. They are nothing. They are like big delivery buses in which a bus, you have taken some amount of triglycerides, some amount of cholesterol, you've got some drivers. Now, as they change shape, as their triglyceride goes off, they convert to a different form. So it's not that they are entirely different. They are the same, basically the lipoprotein, but because they have lost triglyceride, their density becomes more, and they becomes the intermediate density lipoprotein, which does not do much. It has got both triglyceride as well as cholesterol. Now, this IDL is further metabolized into what is low density lipoprotein, in which all this triglyceride goes off. So LDL basically has got mainly cholesterol, and this cholesterol should then be deposited back to the liver. So what we are seeing here in the endogenous pathway is that the liver is secreting triglyceride and cholesterol, which is used here in the circulation. Some of this cholesterol will go to the adrenals to produce that. And when we discussed about adrenal physiology, we discussed as to how adrenals get a lot of their cholesterol from the LDL receptor. Now, after it's been taken care of, the remaining LDL will go back to the bank to deposit whatever is remaining via the LDL receptor and where it is internalized. Now, if the body has got too much LDL, or there is a problem in the LDL receptor, the excessive amount of cholesterol will get deposited in the macrophage, and this is the basis of the cardiovascular disease or the atherosclerosis, which happens with a dyslipidemia or hypercholesterolemia in that perspective. And this is the major problem that we are wanting to avoid in that perspective. Now, VLDL, once its triglyceride is taken off, becomes a smaller molecules, is again taken up by the liver, and it will again reprocess the entire thing in that perspective using the remnant receptor and hepatic lipase. Now, LDL uptake is the single most important part of the entire lipid metabolism. If this is defective, you will have hypercholesterolemia. So we need to know a bit more about that. This process involves the binding of LDL to the LDL receptor and an associated protein. Now, a lot of these receptors have associated protein. We discussed about the ACTH, which has got the mineralocorticoid receptor associated protein, MRAP. Similarly, LDL receptor has got an associated protein. What it does is that once the LDL binds to it, it is captured. And once you capture it, you bring it down inside the cell. So they are like traps for LDL. So they are like waiting. As soon as the LDL is there, they bring the LDL down, form a sort of a membrane around them. And this membrane is then broken via the acidification in that particular area. So basically, the LDL receptor is taking LDL inside. And once it goes into the cell, this membrane is destroyed, the LDL is destroyed, and the body gets the cholesterol back. The liver gets the cholesterol back in the form of cholesterol. It will also get fatty acids and amino acids, and it will again package them into a LDL. So basically, LDL receptor is a recycling form in that perspective. And once free, this LDL receptor will go back to the membrane to fetch more LDL from outside. There is a very important enzyme known as the proprotein convertase subtilisin type 9, the PCSK9, which basically inhibits this recycling. So if there is an inhibitor of the PCSK9, that will assure that there will be much more LDL receptor, causing a lot of this cholesterol to go inside. And this is a very effective form of therapy for somebody who has got a familial form of hypercholesterolemia. So disorders associated with the LDL receptor, disorders associated with the associated protein, and the PCSK9 are associated with familial hypercholesterolemia, which is the most important lipid disorder we'll discuss subsequently in this perspective. Now, conditions associated with increase in cholesterol will inhibit HMG-CoA, which is the major producer of cholesterol in that perspective. So if you have got too much intracellular cholesterol, your LDL receptor will go down, your HMG-CoA will go down. If you inhibit HMG-CoA, your intracellular cholesterol will come down, your LDL receptor will go up. So basically the liver cell will feel we need more cholesterol, it will get cholesterol from the circulation. So if you inhibit the HMG-CoA enzyme, which is the rate limiting enzyme in the production of cholesterol, your LDL receptor will go up and that will internalize cholesterol, causing the effective reduction in the plasma cholesterol. And this forms the basis of the use of statins, the most commonly used therapy in treatment of lipid disorders. Now, we have discussed about 4 major lipoproteins: chylomicron, which is coming from the intestine, getting triglyceride and going to the liver; VLDL coming from the liver, taking triglyceride to the blood, coming back to the liver; LDL, which is basically a remnant, or let's say a metabolite, so to speak, of VLDL, which contains cholesterol, goes back to the liver. But there is a lot of cholesterol which is in the circulation. While the LDL is circulating, it is giving cholesterol to a lot of these macrophages in the bloods, and body doesn't want that excess cholesterol to be there. So we can think of it that we have got a bank, the liver, which has given a lot of money, which is circulating, and a lot of this has become NPA. Now, how we get that NPA back? How do we get that loan back? For that, we have got the HDL pathway. So HDL is the taxman. It is getting the cholesterol, the money out from where it is deposited in people's locker individually. So HDL basically goes out. It extracts the cholesterol from the blood vessel. And this is very, very important. And that's why it is basically associated with improved cardiovascular health. It uses a special cassette, a sort of a tunnel, a ATP binding cassette transporter A1, which then takes cholesterol inside. And then this cholesterol is esterified using this LCAT enzyme, the lecithin cholesterol ethyl transferase. So it's taken out, it is deposited into a fixed deposit. And then very interestingly, this cholesterol is exchanged with LDL and VLDL using this cholesterol transfer protein in exchange to triglyceride. So now if you think of it, what HDL is doing, it is taking the cholesterol from the blood vessel and giving that cholesterol to LDL and VLDL, which will indirectly then take it to the liver. So essentially, HDL is involved in what is known as the reverse transport of cholesterol, and very important from a cardiovascular perspective. So now, once this cholesterol is gone, the HDL becomes smaller, it goes back to the liver, where the further cholesterol goes off, and this HDL becomes to the native form. So HDL is involved in getting cholesterol from the periphery to the liver. And this whole cycle will continue. So just to summarize finally, before we go into more clinical aspects of the talk, the major supplier of lipid is the diet, from which it is actively absorbed using CD36, packaged into chylomicron using the microsomal transfer protein. This chylomicron goes to the circulation, where it is acted upon by the lipoprotein lipase with the help of GP1, HBP1, with the help of ApoC2 to release triglyceride, which is used for the heart, for the muscle, some lipids which are used for the adipocyte formation, as well as the adrenal steatogenesis. This results in shrinkage of the size of chylomicron, which is then taken up by the liver. So from intestine, supply and go. So you've got a big tanker, which is supplied the fuel everywhere, and then it supplies back to the main depot. Then from the liver, this whole lipid goes back into the circulation, again using MTP in the VLDL form, and along with the cholesterol, it goes and again provides triglyceride. It also provides cholesterol in that perspective. This cholesterol is deposited in the blood vessel, in the macrophage, and this is something which is bad from a clinical perspective. To take this cholesterol back, we have got the taxman HDL, which takes this cholesterol back and then exchanges this cholesterol to triglyceride from the LDL, and the LDL is then again taken up by the liver. So if you just think of it as 3 major organs, the intestine, the liver, and the blood vessel, intestine, the supplier, liver, the reservoir, and the circulation, the consumer, we have got chylomicron and VLDL as huge fuel vehicles, which take a lot of fuel and energy for the body. LDL is trying to provide the alternate source, the different form of oil, you can say cholesterol, And if there is too much in the periphery, if people are hoarding it, HDL will take it back. And that's pretty much the summary. So what's bad for the body is low HDL and high LDL. We are not that bothered about VLDL. We're not that bothered about triglyceride, because triglyceride, as we discussed earlier also, is mainly responsible for pancreatitis only when the levels are more than 1,000. So don't bother about somebody who's a triglyceride of 200, 250. Ask for lifestyle, but don't force them into medications. And of course, LDL is taken up by the LDL receptor, LAP, and where PCSK9 plays an important role in that regards. Now, why do problems happen? When we have got too much LDL cholesterol, this cholesterol goes into the macrophages and they then get deposited within the blood cells, causing the formation of the fatty streak, which is not bad. It's just the fat deposited in the blood vessel. This fatty streak will grow to an atheroma. There will then be calcification, rupture, and thrombosis. So this is the first manifestation of of atherosclerosis condition in children. Happens by around 8 years of age. So you have to be very, very cautious in that regards. So now we've discussed a lot about pathophysiology, but I thought that was important to really get things into perspective, because that forms the basis of a lot of our diagnosis, a lot of our therapeutics. We'll now talk about pointers and criteria. So when should we think of lipid disorders? Of course, if somebody has got a family history, and we'll go into more detail subsequently, if somebody has got obesity, acanthosis, renal failure, cancer therapy, those conditions, if you have got attendant xanthomas, or you want to do a routine screening. So these will be the indications of lipid profile. Very importantly, the main aim of all this evaluation is to not miss this familial hypercholesterolemia, which causes premature cardiovascular disease. So when should we think of a familial hypercholesterolemia? If the total cholesterol is more than 240, if there is a family history of a cardiovascular disease before 55 years in male and 65 years in female, and we'll talk about what really means by a CVD, which is an important thing to consider. Somebody, of course, who's got attendant xanthomas, which should not happen in children, either in the child or the family member. And this typically will happen in the Achilles tendon. The extensor surfaces typically are more affected, and the dorsum of hand more commonly. Palmer xanthomas, which we'll discuss later on, are not features of familial hypercholesterolemia. They happen more in the setting of dyslipidemias and the abnormalities basically related to the Apo E2 factors, the beta lipoproteinemias. Now, if the LDL level is more than 160 and there is a family history of hypercholesterolemia, one has to be wary about this. If there's LDL more than 190 without family history, one needs to bother. So these are the conditions where possibly genetic diagnosis will become important in this perspective. Now, what really is a premature cardiovascular disease? And there are specific criteria for that. We've discussed age below 55 in males and below 65 in females, cardiac abnormalities in the form of a heart attack, treated angina, CAD intervention in the form of angioplasty, or a sudden cardiac death. So any of these before this age becomes significant. And remember, we are talking about cardiovascular and not just cardiac. So if there is a ischemic stroke, that itself becomes a CVD risk. And this we have to be very cautious about in that perspective. Now, the other thing to look at is hypertriglyceridemia. So of course, anybody with pancreatitis, measure triglyceride level. Anybody with acute memory loss or visual symptoms, this may be a marker of severe hyperchylomicronemia. You can have lipemia retinalis, which can be seen on a fundus examination or a fluorescein angiography. And of course, the most common presentation to a pediatrician is lipemic serum. So somebody has just separated and the lab will say there is a lipemic serum. Then you should start thinking of the triglyceride levels. Of course, if you have a Palmer xanthoma, this is as against extensor xanthomas for hyperlipidemia, again maybe a pointer of this beta lipoproteinemia, or sometimes even familial lipoprotein lipase deficiency. Now, there's a big debate whether we should screen only those people who have got symptoms or features, or screen everybody. And there are two basic strategies: universal versus selective. Risk factors considered for selective include obesity, diabetes, family history of CAD, hypertension, smoking, familial disorders, chronic kidney disease, cancer survivors, Kawasaki. So these are all risk factors for a cardiovascular disease. Now, most people are now shifting towards a universal lipid screening. And this is something which is very, very important. We are moving from selective to universal screening because this is not going to miss those cases, while selective screening will miss a number of cases, has got a higher level, the cost issues are there. So most people will go ahead with a universal screening at 9 to 11 years. So every child should have a lipid profile as far as the American Heart Association recommendations between 9 to 11 years, irrespective of whether there are risk factors or not. Now that is debatable, but if you look at Indian data, it again says around 7 to 10% lipid abnormalities. So maybe doing a lipid profile at 9 to 11 is good enough, with the repeat at 17 to 18 years. Very importantly, do not do a lipid profile during puberty. As we'll discuss, there is a tendency of decline in the LDL level, so you may miss those conditions. Now, the next question is which test to do and what time of the day to do. So the test we can do is to look at the total cholesterol, triglyceride levels. LDL, of course, is the most validated parameter in terms of long-term cardiac risk. HDL, and these we need to consider. We can also measure VLDL, but how much is it important? So the assessment basically includes cholesterol and triglyceride. Now, within cholesterol, we do measure HDL, and we can measure the non-HDL cholesterol. Now, this is a term which we'll be using a lot. We need to be aware now that LDL cholesterol in most labs is actually the estimated LDL, and it's not the true LDL. It is estimated based upon the HDL lab value and the triglyceride value. Very importantly, it has to be done in that setting, a fasting state. But if you want to do a non-fasting sample, this non-HDL cholesterol is really emerging as a very good marker of cardiovascular risk. And most recommendations now will suggest to do a non-HDL cholesterol rather than a LDL cholesterol to begin with. Now, within the non-HDL cholesterol, we have got LDL, and this can be measured as a calculated one as discussed, or this could be a direct measurement. Not many laboratories are doing that. We have VLDL, the very low density lipoprotein, the intermediate density lipoprotein. So basically all three of them are atherogenic. So why are we just bothered about LDL? Let's combine all three. So that's why this non-HDL cholesterol is emerging as a big cardiovascular risk factor in children in this situation. Now, the problem is that we can also measure remnants, which is just basically the cholesterol, HDL, LDL, and these can be remnants. Again, there can be a bit of confusion. Now, one of the big questions which everybody asks, whether we do a fasting lipid profile or a postprandial lipid profile. Now, what we need to understand is that there will be a dramatic effect on triglyceride with the fasting. Because if you eat, you get a lot of chylomicrons, and 95% of chylomicrons are triglycerides. So if you have a postprandial level, your triglyceride can go up really high. There is not much difference in cholesterol. So if you're mainly focusing on cholesterol, doesn't matter whether you're doing fasting or non-fasting in that perspective. HDL also is not affected a lot. So non-fasting sample can be done for total cholesterol, HDL cholesterol, and the derivative, the non-HDL cholesterol. So this is a very easy thing. Somebody comes to you with obesity, you get those samples immediately. Why wait for a fasting sample? But if you want to really look at a proper evaluation for triglyceride, for a calculated LDL cholesterol, it has to be done on a fasting state. And while non-HDL cholesterol is considered a good screening marker in this perspective, it is not a very good test to base upon therapy. So when you want to do a therapy, you have to really go ahead and do a proper assessment of LDL cholesterol in a fasting state, ideally in two samples, which are 2 weeks to 12 weeks apart. So most people will do that. They will measure LDL cholesterol, do some lifestyle basic changes, unless the LDL is more than 250 when you're really bothered about familial hypercholesterolemia. In that case, repeat it after 2 weeks to 12 weeks, average the value, and that becomes your baseline as far as LDL is concerned in that perspective. Now, there is a lot of variation which may happen with cholesterol. 5 to 10% is individual. So this is going to happen if you take today or tomorrow. There is 10 to 15% laboratory changes. So if your cholesterol is 100, it could be 85 to 115. So you have to be clearly not picking up for every single value of cholesterol. Variation is higher for HDL because the assays are not that robust in that perspective. Certain situation, there could be monoclonal antibodies which can cause falsely high level of cholesterol. So if you have somebody who's got a cholesterol of 800, but there is no xanthoma, there's no family history, don't bother. Do with a different assay and maybe you will find the results to be appropriate in that setting. Now we have a 12-year-old boy with obesity. He is obese, BMI STS is 1.9. He has got a total cholesterol of 180. LDL is 130, slightly on the higher side. Triglyceride is high. Now, whether he requires treatment or not, and this is the question which often as a pediatric endocrinologist we are referred in that perspective. Now, importantly, this sample was non-fasting. In non-fasting, do not rely on the LDL level. And this is the big message. If you want to really look at the calculated LDL, always look at a fasting level. You could have looked at the non-HDL cholesterol here, which probably would not have been that high and nothing to worry in that situation. Now, non-HDL cholesterol is basically the entire atherogenic component of cholesterol. It's basically cholesterol minus the HDL. It covers everything. It includes the LDL, the VLDL, the IDL. It has got all the atherogenic proteins which are there. Very importantly, this is unrelated to meal and it can be used as a screening test. So if you want to look at one parameter in a non-fasting, in a screening test, look at non-HDL cholesterol, and that's very good in that situation. Now, estimated LDL cholesterol is what most labs do. They use an equation wherein they derive the cholesterol based upon the levels. So in cholesterol, what we assume that there is HDL, there is VLDL, and the remaining, of course, is LDL. So what they measure is that they measure the cholesterol level, they measure the HDL level, VLDL is derived from triglyceride. Now, this assumption is based upon the fact that 20% of VLDL is basically cholesterol, 80% is triglyceride. So there is a formula known as Freidwald equation, which basically is LDL is equal to total cholesterol minus HDL minus 20% of triglyceride. And this is the definition which is used by most labs. Now remember, this has to be done only if it's a fasting stage or the triglyceride level is less than 400. If your triglyceride is high, your estimated LDL will be really spurious in that perspective. Of course, if somebody has eaten, you will have a lot of chylomicron, and that chylomicron has got 95% and not 80% of triglyceride, and that also makes it unreliable. Now, the next issue, of course, in this regards is that if the levels are very low, below 25, it's very unreliable. We are not bothered about that in most cases anyways. In that situation, it does not take into consideration the IDL very well. The VLDL is also not very important, and it also includes some of the other forms of lipoprotein which we did not discuss. Lipoprotein A, which is supposed to be more atherogenic, and lipoprotein X. So estimated LDL cholesterol is having problems, but remember, this is the most validated test as far as long-term outcome is concerned in this regard. 14-year-old girl with obesity, BMI standard deviation score of 2.4. So she is reasonably obese in that situation. Total cholesterol is 180. LDL cholesterol is 120. So we are seeing that her cholesterol is on the higher side. Triglyceride is 560. Now, this LDL, of course, is the calculated LDL, and we have discussed that when you have a triglyceride above 400, do not rely on this form of cholesterol. So we do not want to treat her. This is not an appropriate lipid profile assessment. We should do a direct measurement of cholesterol in this perspective because the triglyceride level is very high. Now, to come back to the original question, if somebody has got hypertriglyceridemia, or you're doing it for the first time to decide treatment, do a fasting LDL. If you have shown that there is no hypertriglyceridemia, you just want to follow up, you can follow up using a non-fasting sample. If you want to just screen in the initial phase, do a non-HDL cholesterol. I think that's what is the routine sort of lipid profiles that we'll advise in that situation. Now, direct cholesterol is done when you measure directly LDL. It requires a lot of more sophisticated techniques. It is indicated if the triglyceride level is above 400 or you're using a non-fasting sample. The issues there are, of course, with assay. There is a very poor correlation between the estimated and the actual LDL. And remember, the most validation has been done for estimated LDL. So I would not recommend a routine direct measurement of LDL cholesterol in children unless you have a severe hypertriglyceridemia level above 400. So now what are the criteria for lipid disorders? And this again is a debatable issue. Adults are going away from criteria. They talk about cardiovascular risks, but still in pediatrics, we talk about the acceptable, the borderline, and the high levels. So total cholesterol more than 200, LDL cholesterol more than 130, non-HDL more than 145, HDL less than 40, and triglyceride, there's a dichotomy for 0 to 9 and above 10 years. These are the criteria of high levels. Now, we are talking about these as criteria, but this does not mean that you have to treat everybody at that level, and this is something we need to understand. Very importantly, these are different slightly from the adult cutoff, so please use this table rather than the reference range which is provided by the adult cutoffs in that situation. What about triglyceride levels? Triglyceride levels generally are not that bothersome as LDL. So acceptable, of course, is less than 100 and less than 130. We are mainly concerned when they go above 500. And once they go above 1000, there is a big risk of developing pancreatitis. So we always vary of a TG level more than 500. More than 1000 is, of course, something which you're really bothered about in that situation. This is mainly related to pancreatitis. There is not much cardiac risk. There may be some incremental risk which may happen with regards to some of the other illnesses, but it's mainly the pancreatitis risk we are looking at. And of course, if you have got severe hypertriglyceridemia, there could be some neurological problems which may happen. Now, based upon that, we'll just summarize the approach to lipid screening in children to a non-fasting sample to begin with and look at non-HDL cholesterol. If the non-HDL cholesterol is less than 120, it's fine, nothing to worry. If it's 120 to 144, you start off with lifestyle measures and then repeat after a year. If the non-HDL cholesterol is above the upper limit, that is above 145, you should do a fasting LDL 2 samples at 2 and 12 weeks. So you have to do 2 samples and then average the value out. It's 130, 140, it becomes 135. And if it's less than 110, fine, just follow up. 110 to 129, lifestyle, and maybe repeat the sample again. If it's 130 to 250 or 249, you start thinking of treatment in that perspective, especially looking at the cardiovascular risk and looking at other causes like diabetes, hypothyroidism, liver disease. These all have to be looked out in this perspective. Levels more than 250, you have to think of a familial hypercholesterolemia and consider treatment. So basically, from a pediatrician perspective, please do a non-fasting HDL in somebody who you're thinking of lipid disorder. If the levels are more than 145, then do a fasting LDL. You do it in 2 occasions. And if they are persistently high beyond 130, there is a need for evaluation from a pediatric endocrinologist. More than 250, 100% immediate evaluation is required in terms of multiple issues, which we'll discuss subsequently. Now, the other parameters which are sometimes used include the lipoprotein size. This is based upon the fact that some children with insulin resistance and adults, particularly with diabetes, have what is known as small, less dense LDL. And this is supposed to be more atherogenic. This may be missed if we actually look at LDL cholesterol mass. So they talk about numbers. If your LDL number is more, you will have more risk. But this is more of a experimental measure at the moment, not recommended routinely in children. This can require sophisticated techniques like MR spectroscopy or a gradient electrophoresis. It's mainly research for metabolic syndrome. The other thing which people use as a surrogate marker of high atherogenic cholesterol is Apo B, which basically is an indication again of a lipoprotein number. It provides information about LDL, VLDL, and IDL. These are the 3 atherogenic proteins which we discussed. It's again more of an experimental, more for cardiac risk evaluation. not in routine clinical practice. So from a clinical perspective for a pediatrician, I would say a non-fasting, non-HDL cholesterol is important. Of course, you will do a triglyceride and the triglyceride is very high, you start worrying, but focus mainly on the non-HDL cholesterol in a non-fasting sample, more than 145, start getting worried for a lipid disorder in that perspective. So we have now gone through the different aspects of the evaluation and the pathophysiology of lipid disorders. We'll quickly see if there are any questions we'll take up now before going on to etiology. So we have got a question from Dr. Kriti, who asked about, can hypertriglyceridemia occur with acute infection? Yes, so hypertriglyceridemia is known as part of a few conditions in which we do encounter particularly systemic infections, but not very commonly. The systemic illnesses in which I have seen hypertriglyceridemia is a thoracic duct dissection, which can happen because that is where all the chylomicrons are going and they can cause severe hyperchylomicronemia. Dr. Shala, we definitely can manage, we can definitely see direct cholesterol, but that's not something which is easily available from a clinical perspective. And this is something which can be done and is not recommended for everybody. Is recommended for somebody who has got a very high triglyceride in that situation. So if there are any questions with regards to the talk till now about pathophysiology or about clinical evaluation and pointers, if they are not, we will move forward to the etiology, which itself is a big issue to consider, but it's much easier since we have discussed the entire pathophysiology. So abnormalities can happen in different parts of this pathway that we discussed. There could be an abnormality in the hepatic, the gastrointestinal absorption because of these ATP binding cassettes which shift the sterol into the body. So what will happen in this condition is that all the plant sterol, which is pushed off by the intestine, gets into the body. And this is known as a condition known as cytosterolemia. The plant sterols go up really high, and these levels are remarkably high in that condition. Rare condition, difficult to diagnose, but important, easy to treat, because what you need to do is just to inhibit the gastric absorption, and you will get a good result in that perspective. Major abnormalities that we will see for cholesterol are at the level of the LDL receptor, abnormalities in the LDL receptor, the associated protein, the PCSK9, activation of PCSK9, Apo B, they will all cause similar manifestations of familial hypercholesterolemia. Abnormalities can happen at the level of VLDL secretion, which will cause a mixed pattern associated with both high cholesterol and high triglyceride. Abnormalities in lipoprotein lipase at the level of ApoC2 and ApoA4, and this sphingolipid GP1 HBP1 is associated with familial hyperchylomicronemia syndrome, very, very high levels of chylomicron in that perspective, very high triglyceride. Abnormalities may also happen in apolipoprotein. So abnormalities in ApoA1 will cause low level of HDL cholesterol. Abnormalities can also cause Tanger's disease, which is a very interesting disease in which all the cholesterol is in the blood, doesn't get back. So you will have very low HDL, but your tonsils will look yellow because it has got all the cholesterol there. There could be abnormality in the cholesterol transfer as well. So lipid disorders can be primary, in which majorly we are talking about LDL disorders, including LDL receptor, associated protein, PCSK9, abnormalities in Apo B-100 and lysosomal acid lipase. Abnormalities in VLDL includes familial combined dyslipidemia, familial hypertriglyceridemia. Triglyceride abnormalities include lipoprotein lipase, GP1, HBP1, which is a cofactor for LPL. It gets lipoprotein lipase into the cell. ApoC2, which is part of the chylomicron or the VLDL, which is required for LPL activation. Apoprotein abnormalities like ApoA1 causing low HDL, ApoE causing this beta lipoproteinemia. So abnormalities in LDL and VLDL will cause high LDL, while those in VLDL and triglyceride will cause high triglyceride in association with high LDL. Apoprotein abnormalities typically will have a low HDL. Now, lipid disorders will happen in a number of secondary disorders, And these will include obesity, diabetes, cancer, drugs, kidney, liver disease, and all of this we need to be aware about in that perspective. And of course, the endocrine perspective, hypothyroidism is extremely important in that perspective. We'll go one by one into these conditions. So we have got this autosomal dominant form of LDL receptor problem. This is the most common lipid abnormality that you will see. This basically happens because of a heterozygous defects, autosomal dominant condition. In around 1 to around 300 cases, cholesterol is not very high, 250 to 400. They will have a slightly earlier CAD. So they will not have that very early CAD. They will have cardiac disease by around 30 to 60 years. But again, this is very, very preventable and treatable. Xanthomas in children would be rare because cholesterol are not going up really high. Now, heterozygous familial hypercholesterolemia should be suspected in anybody who has got a LDL above 155 with a family history of familial hypercholesterolemia, premature cardiovascular disease, or xanthomas. The genetics of this involves association for the LDL receptor, association for PCSK9 and Apo B. This is not essential, but once you diagnose these genes, you can then do a screening for all the family members to pick up what is known as the cascade screening in this situation. Very importantly, we have to exclude conditions like diabetes, hypothyroidism, nephrotic syndrome, glycogen storage disease. They can cause very high levels of cholesterol in this situation. We have an 11-year-old boy with suspected familial hypercholesterolemia. LDL is 280. He has got a high triglyceride as well, and this is unusual. Generally with FH, triglyceride is not affected. Father has a high cholesterol and statin, no cardiac disease, but still people thought that this is significant, and he was advised a very high dose of rosuvastatin, 20 milligrams. Now, do we need to do something else? Of course, in this case, what we are seeing is that his levels are more than 250. We need to evaluate and treat, but of course, we have to treat for other causes as well. So he had significant growth failure and turned out to be hypothyroidism. So secondary causes like nephrotic, liver disease, diabetes, hypothyroidism, all of them have to be excluded in this situation where the LDL level goes up. It's a diagnosis of exclusion. The autosomal recessive form is essentially the double dose. So you've got a double dose in that perspective, and this will result in a situation of severe form of hypercholesterolemia, a rare situation in around 3 to 4 lakhs. The manifestations of cholesterol are very high. They will be like 500, 600 to 1000 as well. They would behave very, very severe. The parental lipid profile may be normal or abnormal in that perspective. Now, homozygous familial hypercholesterolemia should be suspected in the setting of high LDL cholesterol. Untreated levels will be above 500, while treated levels will be above 300 in that situation. Along with that, we should have either a tender xanthoma before 10 years of age, high LDL in both parents, or also we can think of other genetic disorders in the form of LDL receptor, PCSK9, and Apo B. So this is the most severe form of hypercholesterolemia, extremely difficult to treat. Give the highest dose of statin, add a second-line agent, consider LDL apheresis, because some of them may actually develop a cardiac abnormality within 10 years of age. So this is something which we cannot afford to miss in that perspective. Now, PCSK9 defect is a phenocopy of this autosomal, this familial hypercholesterolemia. In this condition, the LDL receptor is basically not getting inactivated, and therefore the LDL receptor is effectively knocked off. This is activating mutation of the PCSK9. This LDL receptor is getting inactivated. It's a LDL receptor deficiency. Because of this, behavior will be pretty similar. They will have a high level, but it's milder compared to the classic form. There could also be abnormality in the LDL receptor associated protein, again presenting with a similar abnormality. Manifestations are high cholesterol. It's milder than the severe variety, of course. The Apo B-100, again same. So again, Apo B, LDL receptor, LAP, and PCSK9. All four are phenocopies. You can't differentiate just based upon the clinical parameters, and genetics becomes important. So Apo B-100, impaired LDL receptor binding. It presents with very high levels of LDL cholesterol, high LDL and normal triglyceride, and tendon xanthomas can be there in this situation. So this is again a defect you have to think of. Now, this is a very interesting condition, the lysosomal acid lipase, which is basically acidifying the cholesterol. So cholesterol is not getting acidified and it gets really deposited in the liver. So this condition will present with a reduced acidification, resulting in a mildly high LDL level associated with low HDL and high triglyceride and massive hepatosplenomegaly with high ALT levels. This is a differential of NAFLD. The severe form of this will result in adrenal insufficiency because there is no cholesterol ester at all. The milder form presents more with a hepatic involvement, mainly in the setting of what looks like a non-alcoholic steatohepatitis picture in the situation. And they have a later onset of CVD as compared to the other ones. Now, we discussed about this rare condition, hypercholesterolemia, in which the problem is basically increased absorption of plant sterols. So normally we say plant sterols are good because these plant sterols will actually be lost. 90% of them will be lost by the intestine. But here this loss is defective. Therefore, you will have greater accumulation of these sterols. This is the ATP cassette defect, reduced sterol loss, presenting mainly with very high levels of plant sterols. Cholesterol levels are usually variable. They have a tendency of premature CAD and xanthomas, which can be observed in this situation. They tend to improve with diet, and very importantly, ezetimibe, which basically acts on the same cassettes, will be a very effective therapy in this perspective. Now we've discussed about the LDL problem, a word about the VLDL problem. These are the most common overall cause of dyslipidemia. So most of those familial dyslipidemia that we talk about in adults, in older children, is this basically familial combined hyperlipidemia, where basically there is an increased production of hepatic VLDL, resulting in a high cholesterol and triglyceride level. This is associated, a common condition, 1 to 2% of population will have that. They will have high cholesterol, high triglyceride, and high Apo B level. So this is a common condition. They behave and they'll be worsened by a metabolic syndrome or obesity. Now we have a 14-year-old girl with obesity. BMI is 2.1 STS, acanthosis. There is some pre-diabetes which is there. So there's impaired fasting glucose, and we've got just impaired glucose tolerance. LDL is high, triglyceride is high. This is not the classical familial hypercholesterolemia. This is a problem of VLDL. This is basically a combined, a common family history you will find in the family members, which will be there. And this usually is managed with lifestyle measures and, if required, statin, as we'll discuss subsequently. Now, VLDL excess can also cause familial hypertriglyceridemia, in which there will be overproduction causing larger particles. You've got more triglycerides. Here the triglyceride levels will be high. LDL typically happens to be normal. Again, a common condition, 5 to 10%. Remember, high triglyceride is bad, but only if it's more than 1,000. 500 to 1,000 has the potential of pancreatitis. Less than 500 is pretty all right from a clinical perspective, and we don't need to bother about that. Very importantly, this form may be precipitated by a number of drugs and estrogen. So particularly these individuals may be fine and you suddenly give them estrogen for some reason, you give them oral contraceptives, you treat them for PCOD, they will develop hypertriglyceridemia, they will develop pancreatitis, which may happen in the situation. So now we've discussed about the VLDL disorder, a word about the triglyceride disorders, which are the second commonest, presenting to a severe form to a pediatric endocrinologist. Most common disorder is at the level of lipoprotein lipase, which is a key enzyme for metabolism and release of triglyceride. So your chylomicron has to be dissolved by this lipoprotein lipase. So if this lipoprotein lipase is defective, you will have a huge amount of chylomicron, and this is known as familial hyperchylomicronemia. It's a rare condition, 1 in 100,000, but one which is very, very difficult to treat in the situation. It presents with very high level of chylomicron. You will have that lipemic serum, pancreatitis, hepatosplenomegaly, neurological features because of this very high chylomicron, which will make the blood viscous. They will have a lipemic serum and difficult to treat in the situation. People have used plasmapheresis, they've used gene therapy in the situation. The other abnormalities in ApoC2, ApoA4, and GP1-HPP is also associated with a similar perspective. Now, ApoE4 defect is a rare form of hyperlipoproteinemia. This basically is associated with variation in ApoE4, resulting in reduced clearance of chylomicron and VLDL. Manifestations are with high VLDL and chylomicron and high triglyceride levels in the situation. It is a variant of type 5 hyperlipoproteinemia. So we have discussed about the LDL, the VLDL, the triglyceride. What about these apoprotein abnormalities? And these are some interesting abnormalities which we need to be aware of in that perspective. So ApoA1 problems are associated with reduction in HDL cholesterol. So HDL is really lost in that perspective, but you cannot get the cholesterol out from the cells. The manifestations are low HDL, normal level of other lipids, but still CAD risk. So if you have somebody whose HDL is 7, 10, 15, normal LDL, think of a hypo-alpha lipoproteinemia. LCAT defect is again a defect in which the cholesterol is taken by the HDL, but it is not esterified. And this defect is associated with a very low level of mature HDL. The levels are less than 10, and the CAD risk would be variable in that perspective. A similar abnormality happens with the ABC cassette transporter defect, which is known as Tangier syndrome, which we discussed briefly, is a condition associated with reduced withdrawal capacity from the cholesterol from the xanthomas. It presents with very low HDL cholesterol along with yellow appearance of tonsils, and this is a characteristic clinical picture to think of. It is mild to moderate cardiovascular risk in this situation. So we have a 10-year-old boy with routine screening found to have a cholesterol which is all right, triglyceride is all right, but somebody found a HDL of 5. So this is extremely low. And when we did an examination, there was a yellow tonsil. This is a classical picture of ABCA1 defect or Tangier syndrome. Couple of very interesting conditions: A-beta lipoproteinemia, which is a problem of MTP, which is the microsomal transfer protein, which transfers the lipid into the chylomicrons. And if this is defective, there would be low chylomicron and VLDL. The manifestations include that there will be no production of VLDL and chylomicron, so there will be massive steatoria. All the fat is lost. If you're losing all the fat, you will have fat-soluble vitamin deficiency. There will be a vitamin E deficiency resulting in neurological features. So A-beta lipoproteinemia mainly presents with steatoria and vitamin E deficiency resulting in ataxia and neurological features in that perspective. Another important condition is beta lipoproteinemia, which is an abnormality at the level of ApoE. So this ApoE is responsible in clearance of a lot of these chylomicron, VLDL, and those things. So this ApoE metabolism defect will present with remnant amounts. This will result in an eruptive Palmer xanthoma. So as discussed, hypercholesterolemia is associated with either a plantar or a dorsal xanthomas. If you have a Palmer xanthomas, think of this beta lipoproteinemia in that perspective. It is associated with a later onset cardiovascular disease. And the other cofactors can worsen like diabetes, thyroid, and obesity. So 10-year-old girl with eruptive xanthomas, she is not obese, LDL is okay, TG is mainly high, and VLDL is low. So this is a typical abnormality of this beta lipoproteinemia in that perspective. So now these primary disorders will probably be 1 to 5% of your entire lipids, but they are the most challenging. But now what we are seeing more is these secondary disorders of lipids, which are very, very important. So we need to know when to evaluate for lipids in obesity, in diabetes, and other conditions from that perspective. And the American Health Association guidelines are extremely wonderful with this regards, and that everybody should go through. I'll share the link subsequently. So secondary hyperlipidemia, the most common cause, of course, will be obesity. It's because of insulin resistance and inflammation. The features include a high level of total cholesterol, triglyceride, and a low HDL in that perspective. And obesity and insulin resistance mainly causes small, dense LDL, which is common, which are more atherogenic. The workup should include workup for other things like blood pressure, glucose, liver function, and lipid. The management again is risk-oriented basis, it's lifestyle, and statin should be given, and we discuss subsequently based upon how much is the cardiovascular risk of that particular individual. 17-year-old boy with morbid obesity, BMI is very high, he has some impaired glucose tolerance, cholesterol is very high, and this is the risk assessment which we discussed. So if you talk about somebody with severe obesity, he comes in a moderate risk category. So for a moderate risk category, the parameters are that you should repeat the levels after 3 months, and if they are persistently above 160, you start statin. So even in a moderate obesity, not everybody should be immediately started with statin. Remember, statins are good drugs, but they have got potential side effects. Very wary about statin in women and girls because they have a risk of teratogenicity. They are contraindicated in pregnancy. So be careful in starting statin in that situation. Now, diabetes, again, we do a lot of lipid profiles in diabetes. So this is common because of insulin resistance and lipotoxicity, and there is a definite cardiovascular risk. Type 1 and type 2 diabetes themselves are considered to be a severe risk. So if you have a child with type 1 diabetes, he is at the age of 40 years equivalent to somebody who has had an MI without having an MI. So it itself becomes a risk factor. That is the basis of the AHA recommendations, and importantly, they're associated with a similar picture like obesity with small, dense LDL, which are common. The workup should include lipid profile, and if you have a confusion, maybe Apo B if it's available, and glycemic control is very, very important. Treatment, importantly, has to be started early. So we use different cutoffs for LDL, which is less than 100 for treating somebody with type 1 or type 2 diabetes. Start statin after 10 years of age and do a good glycemic control in that regards. So 14-year-old girl with type 1 diabetes, diagnosed 4 years ago, has a highish HbA1c, cholesterol is high, LDL is 134, triglyceride is high. So what do we do? Very importantly, this is the highest risk of CVD as far as the AHA criteria. She is as high risk as a homozygous familial hypercholesterolemia. You have to start statin and maintain the LDL level less than 100 in this situation. What about renal failure? Again, this is because of vasculopathy and inflammation. Cardiac effects are also there. This also has a predisposition of calcification, which is very worse in terms of cardiac outcome. This is more atherogenic. The management is with statin and management of blood pressure. Cancer treatment is associated with premature CVD because of the effect of radiation, both cranial radiation, the use of steroids. The predictors of that includes obesity and increased fat. It can be prevented with lifestyle measures, but be cautious in monitoring these individuals for metabolic syndrome in the form of glucose tolerance tests in lipid probably annually, and start metformin and in somebody who has got hyperphagia octreotide. So this is again, so we always know about obesity, about diabetes, but now we have got newer indications like cancer survivors, like somebody who is chronic kidney disease to evaluate very carefully for their effects. Now, as we were discussing earlier, a number of systemic illnesses can also cause lipid abnormalities like liver disease, biliary cirrhosis, hepatitis, cholestasis, infections like HIV, antiretroviral therapy. They will cause a lot of triglyceride rise, which is there. They again cause a small dense LDL, which will rise. Endocrine conditions like hypothyroidism, of course, is important. What about drugs? A number of drugs will affect the lipid profile, and these include, of course, steroids. So this includes progesterone, estrogen progesterone combination, very importantly. So you may have a girl whom you're starting for PCOD with diene, and suddenly she will end up in pancreatitis because the levels go up. So monitor for their blood pressure, monitor for their lipid profile once you're starting estrogen. Corticosteroids, androgens, of course. Very importantly, cyclosporin and corticosteroids can worsen the triglyceride profile in cancer survivor. Systemic management like retinoic acid and valproate, of course, can also cause metabolic abnormalities. Many drugs predominantly have an effect on triglycerides. They include the oral estrogens, antiretrovirals, beta blockers, and alcohol. So these are something we need to be really wary about in somebody who is known to have a higher level of triglyceride in that perspective. So we've now discussed extensively about the overall pathophysiology, the pointers of criteria, the etiology, and we have gone into much more detail because it's just not something which is not often covered in pediatric endocrinology training overall. So we thought we'll cover each and every aspect in detail. We'll now talk about practical assessment of somebody who has got a lipid disorder. So clinical evaluation should include evaluation for things like hypothyroidism, nephrotic syndrome, liver and kidney disease, and of course, history of cancer therapy. Look for drugs which can cause this lipid abnormalities, lifestyle measures, abnormalities like BMI, look at physical activity, dietary intake. Examination should include xanthomas, cardiac examination, and blood pressure. Very importantly, think of genetic studies in somebody who has got familial hypercholesterolemia. You're looking at abnormalities in the LDL receptor, PCSK9, Apo B-100, while high triglyceride, you're looking at lipoprotein lipase, GP1HBP, or ApoC2. So this genetic screening is important because this really gives you a diagnosis and allows you to prognosticate them in terms of long-term follow-up and outcome in this situation. Now, cascade testing, once you diagnose, as we have been so used now with COVID-19, if you pick up one, you do a contact tracing of everybody. Same is true in the setting of these FH conditions. Do a screening of all first-degree relatives of familial hypercholesterolemia by a non-HDL cholesterol or a fasting LDL. And this should start by 2 years of age. So if you have a cardiovascular risk, you don't wait till 10 years, you start at 2 years in terms of evaluation, because that's when you want to act, particularly in these severe conditions. Now, very importantly, look at the cardiovascular status. So you can look at using ultrasound Doppler. These are more research tools like flow-mediated dilatation or carotid thickness. But somebody who has a familial hypercholesterolemia should ideally undergo a CT scan to look for angiography. And this is something which is important because they may have very early onset ischemic disease in this situation. And this CT also gives information about the coronary calcium, which is a known risk factor for a cardiovascular disease. Conventional angiography is not recommended routinely, but if CT angio is abnormal or high risk, we can consider that in that situation. Now, homozygous familial hypercholesterolemia is even more challenging. Always do echocardiography to identify supravalvular aortic stenosis as discussed. In the initial case, look for cardiac motion abnormalities. Ischemia, very importantly, do a ECG at baseline, treadmill test, and of course, angiography would be recommended in this situation. Very importantly, features of cardiac abnormalities, the ischemic heart disease in children are not very, very clear. These symptoms could include pallor, sweating, ear and throat pain, nausea and vomiting, and can be missed. So be more cautious in somebody who has got a cholesterol level of 500 or 600 and is persistently high in that situation. 11-year-old boy with xanthoma, this case we discussed, presented with respiratory distress. This could actually be a supravalvular aortic stenosis, as was found in this case, or could even be a myocardial infarction. So you have to be very, very cautious in this situation to identify this condition appropriately. So we have gone through in details. We'll try to cover a bit about management, and then we'll close after a few questions and discussions which are there. Management of lipid disorders has really been very importantly shifted in adults. Now in adults, nobody talks about the levels, they talk about the cardiovascular risk. And in children, we are still, in a way, even the Endocrine Society guidelines talked a lot about the levels of cholesterol. Now we've got this wonderful AHA statement on cardiovascular risk reduction, which really has for the first time looked into the risk factor-based management of pediatric hypercholesterolemia, and this is highly recommended. All of you, please go ahead and look at this American Health Association guidelines to how to reduce the cardiovascular risk, because everybody believes that it's the children where we can do the maximum. So what they have done is that they have classified people into 4 groups: high risk, moderate risk, at risk, and no risk, based upon these parameters. So high risk includes anybody who has homozygous familial hypercholesterolemia, type 1 or type 2 diabetes, end-stage renal disease, Kawasaki disease, cancer survivor, and these are the conditions you have to be very, very aggressive in terms of treatment. Then there is a moderate risk group, which basically has a heterozygous FH, anybody with hypertension, morbid obesity, pre-dialysis CKD, and some of these cancer survivor and cardiac defects. At-risk individual, and most of our patients will be at risk, will include dyslipidemias, NAFLD, PCOD, obesity between 95th to 99th percentile, and many of these abnormalities. So you should use this table, and this is wonderfully put by the American Heart Association to really decide what group your patient comes into. Don't go by the HDL, the LDL, the total cholesterol level. Go by the risk category and then manage accordingly. And how this is interpreted is that look at the CVD risk, and this is after 10 years of age. Remember, most cases statins are used after 10 years. We'll come back when should be used before 10 years, but after 10 years of age, if your CVD risk is high, like homozygous FH, diabetes, ESRD, solid transplant, Kawasaki, or stem cell transplant, in that case, don't wait. Start statin and lifestyle. And you want to maintain your LDL level less than 100. So the cutoff here is less than 100. So as the girl with type 1 diabetes, we said 130, start treatment. Don't wait here. This is a very high risk. If it's a moderate risk condition, which includes severe obesity, heterozygous FH, hypertension, CKD pre-dialysis, aortic stenosis, coarctation, were the entire list there in the AHA guidelines. Look, start with lifestyle, repeat after 3 months. If after 3 months the cholesterol is LDL is above 160, you start treating with statin and maintain LDL less than 130. So what we are seeing from high to moderate is that high, start statin immediately. For moderate, you wait for 3 months. The cutoffs for management is less than 100 for high and less than 130 for moderate category. Somebody who has got basically at risk, like mild obesity, this is what the most patients will come to us. Mild obesity, fatty liver, PCOD, HIV, Kawasaki. So somebody who doesn't have diabetes, most of our patients will probably come here for a pediatric endocrine perspective. In this situation, start on lifestyle, of course, repeat after 6 months. So don't hurry. They are not talking about giving statin to everybody here. So wait for 6 months. If it's above 160 again, start statin, maintain less than 130. If there is no risk, so you've just done a lipid profile, because now AHA is talking about doing lipid profile at 9 to 11 to everybody without risk factors. In that situation, what you do, start lifestyle, repeat after 6 months, above 190. So in somebody with no risk, you're talking about a cutoff of 190 to treat and 130 to maintain. So once you're treating, you're pretty much 130. So as the risk goes up, your cutoff for waiting 6 months to 3 months to 0 months, your cutoff for treatment 190, 160, 100, and maintenance less than 130, less than 100 goes off. So always do this 2 into 2 table. Okay, this is my risk factor and this is my cholesterol level. What do we do? And if you look at this flow chart, this basically tells you very, very clearly. And in our app, you're going to come up soon with a management pathway for dyslipidemia, which will be based upon this AHA guideline, which is wonderful in terms of how to manage. It really clears off our mind when to use statin and when not to use statin. Now, management before 10 years of age is only indicated if there is a significant high-risk cardiac condition with a very, very high family risk. So this is basically familial homozygous hypercholesterolemia, very high LDL cholesterol above 400, severe conditions of heterozygous rarely, or if the triglyceride is above 1000. So otherwise, less than 10 years, don't rush for treatment in this situation. Now, very important lifestyle interventions, of course, are that you reduce your energy intake from fat, increase intake from mono and polyunsaturated fats, decrease saturated fats, and really avoid the trans fats in diet. Physical activity, 45 minutes daily. Advised weight loss, 5 to 10% decrease in BMI, SDS. Avoid nicotine, very importantly, from a hypercholesterolemia perspective. In severe condition, you can reduce the energy intake from fat to less than 25%, saturated fat less than 7%, cholesterol less than 70 grams, and this is in tune with the child 1, child 2 diet, which is recommended by the American guidelines in that perspective. Now, nutrition should include reduced saturated fat, more fiber, 6 to 12 grams, vegetable food-based diet, and you can also add a plant sterol or a stenol in the form of margarine, which may be beneficial. So they are basically not absorbed and they take a lot of fat along with them. The fat choice, very importantly, would be high in terms of poly and monounsaturated fat, low in terms of saturated fat, and no trans fat, as discussed. Dietary supplements which have been used in these situations include sterols. They basically reduce absorption of fat, as discussed. They are associated with mild reduction in LDL, not very commonly used in children in this situation, and they may cause malabsorption. So now what are the treatment options we have in terms of treatment? So the most common things that we can start working off, we can reduce, of course, the lipid intake. We talked about nutrition. We can block the cholesterol from getting absorbed by using binding agents. We can decrease the receptors which allow the cholesterol to come down using ezetimibe, which is a gastric absorption inhibitor, so to speak. We can, of course, inhibit the HMG-CoA, which is the statin therapy. We can inhibit PCSK9, and this is the latest treatment in the form of the PCSK9 inhibitors. We can also have an impact on the chylomicron formation by inhibiting MTP, which is lomitamide, and we can inhibit Apo B-100 using mipromycin. So statin is by far the #1 drug. The second drug is ezetimibe, and all the other are experimental therapies in this perspective. So statins are clearly, and we'll talk a bit about statin because they're very, very important. They inhibit HMG-CoA. They cause increased LDL receptor expression. They reduce triglyceride by 25 to 40%. The effects are, you have to start around 5 to 40 milligrams per day. So start with a higher dose in somebody who has a familial form, maybe 20 milligrams of rosuvastatin. Nighttime is better because that's when the levels really go up. Start at low dose in other patients and gradually titrate to goal. Fasting lipid should be done after 2 months to really identify in that situation. So in the initiation, do a baseline workup for fasting lipids, HbA1c in sugars, look at SGPT and creatinine kinase because these are going to be modified once you give statin. After you do that, you've got a choice of different statins. They are pretty similar in terms of efficacy. Rosuvastatin and atorvastatin are the ones which are most commonly used, from 10 to 5 milligrams to begin with, and you go up to 20 to 40 milligrams for 20 for rosuva and 40 for atorvastatin. Follow-up should include 4-week later lipid profile, ALT, creatinine kinase, and HbA1c, and then you do 6-monthly lipids and HbA1c. Treatment targets basically should include for high-risk factors less than 100, for moderate at risk less than 130. So if you look at this, you will get the entire understanding of how to initiate, how to monitor, and how to meet the targets of lipids in that perspective. Now, adverse effects of statin are not very common in children. They include myopathy, particularly common in adults, elevation in liver functions and creatinine kinase, and that's why we talked about a 4-week level of ALT and creatinine kinase. New onset diabetes, not very common in children, but has been reported in adults. So you have to be wary about that. Risk factor for these include the use of concomitant azoles and cyclosporin, which may inhibit the metabolism of these compounds, and of course the use of estrogen and progesterone. They are teratogenic, so should not be used during pregnancy and childbearing age group or lactation. Ezetimibe is an inhibitor of this ATP binding cassette, which causes loss of sterols. So basically it impairs the absorption. The effects are given a good effects, 20%, 10 milligram per day. It is an add-on agent, not really approved except for familial hypercholesterolemia. Most of those patients will require ezetimibe along with statin. Bile acid binders are not very popular in children. They cause a lot of gastric abnormalities. They will cause bloating, mild reduction. So ezetimibe is better as compared to these bile acid binders. So we won't be using them in clinical practice. The most important new development in terms of management of lipid disorders in children is the development of the PCSK9 inhibitors, which basically inhibit this protein, which is a metabolizer of the LDL receptor. So if you block this, your LDL receptor will go up. So it is very effective in the homozygous familial forms. Of course, if there is no LDL receptor, it is not going to work. So this basically decreases PCSK9, decreases LDL receptor metabolism. It is indicated about 12 years as an injectable therapy, not for somebody who's got a 0 LDL receptor, of course. There is also some agents which are rarely used now. Apo B inhibitor, it's a new experimental therapy which basically inhibits the Apolipoprotein B. It is effective in severe familial hypercholesterolemia cases. The weekly injection is used. The other agent is lometamide, which is basically going to inhibit your microsomal transfer protein. It basically reduces VLDL in chylomicron. It is effective in, again, familial hypercholesterolemia, and it's available for oral use as against the PCSK9 inhibitors. It has got some hepatotoxicity. Now, the most challenging condition that you will treat is homozygous FH, which is very important to start right at diagnosis, maybe even at 3 years, 4 years. Start with a high potency statin. Start at maybe 20 milligrams of rosuvastatin and 40 milligrams of atorvastatin, because cholesterol is around 700. And this will bring it down to maybe around 300. It's not going to make a huge difference, but start with a high potency statin. Titrate, try to achieve a LDL less than 135, very difficult to achieve. Use ezetimibe early in therapy, 10 milligrams in addition. Refractory cases may require mipomersem or lometamide, or now we've got PCSK9 inhibitors, but again, very expensive, not easy to available. And LDL apheresis is used in somebody who has got a very, very high cholesterol level in the situation. If somebody has got established cardiovascular disease, it's advisable to use aspirins or beta blockers as indicated in a routine perspective. Coming on hypertriglyceridemia, the options basically are only to treat if the levels are more than 1000, if the levels are more than 500 with pancreatitis, or if there is a high non-HDL cholesterol with a high level between 150 to 400. So basically the treatment will depend upon the overall clinical perspective. The options include lifestyle measurement, omega-3 acids, fibrate niacins, plasmapheresis, and try to keep it less than 500 because 1000 is the risk factor for cardiac disease. Nutritional intervention in hypertriglyceridemia are different for somebody who has got a mild to moderate disease, in which you want calorie restriction. Fat restriction is not very important, but you want to have a healthy diet overall, lose some weight, and use omega-3. For severe forms, do not try weight loss. If you have got a triglyceride more than 1000 and the patient loses weight, he will develop pancreatitis. So somebody who has got a severe hypertriglyceridemia, do not go for weight loss. Q fat restriction, very important. Omega-3 has got no impact, and they should not take alcohol at all. So if you have a mild hypertriglyceridemia, it's different. You do weight loss, you do lifestyle. For severe, you require much more than that, and that can be quite dangerous in that perspective. Omega-3 acids have been shown to reduce VLDL production. They are beneficial by reducing triglyceride around 50%, and they are mainly used in children in the initial phase of treatment. The most important therapy in this perspective is fenofibrate, which basically decreases VLDL production. It also increases degradation. So effectively your triglyceride level comes down, HDL levels goes down, and it will cause myopathy, which is more common with statin, and micronized form is available for therapy. Niacin is an agent which is associated with improvement in parameters. This associated with reduced LDL level. The effects are at around 20 to 30% reduction in LDL, 1 to 2 grams per day. Not commonly used in children because it will cause a lot of flushing. It will cause myopathy and liver disease. So if you talk about hypertriglyceridemia, very severe level, start off with fibrate, start off with omega-3, do other complete fat restriction, less than 30 grams per day, and think of all the other measures to avoid triglyceride to go beyond 1000. In that case, you can even do a plasmapheresis in that perspective. HMG-CoA inhibitor are the associated agents which can also help in reducing some amount of VLDL. They are indicated for a supplemental role if the apolipoprotein level is very high or the LDL particle is very high. A high dose rosuvastatin may be effective in this situation. So severe hypertriglyceridemia, and this is a common condition with the pediatric endocrinologist will see, we can use a VLDL option to block fibrate. We can use plasmapheresis if the triglyceride is more than 1000. Lipoprotein lipase gene therapy in the form of Glybra. ApoC2 inhibitors like volnosarsen are the ones which are used in that perspective. So mainly we will be using fibrates, probably also omega-3, and consider plasmapheresis. These two are complex, not easily available in the routine practice yet. So just to summarize, the management of hypertriglyceridemia depends upon triglyceride level. Less than 149, no treatment. Above 1000, fibrate and niacin. If there is a high non-HDL cholesterol, start statin. Think of plasmapheresis as very high. And there are other options like Apo C2, C3 inhibitors, and gene therapy. 149 to 499 and 500 to 999 depends upon whether the non-HDL cholesterol is high. If it's high, you start treatment. If it's not there, you can wait. If somebody is between 500 to 1000 and history of pancreatitis, the treatment is indicated. So patients who have got a triglyceride more than 1000, more than 500 with pancreatitis, and more than 150 with a high non-HDL cholesterol, start therapy for hypertriglyceridemia. And if, of course, nothing is there, there's no need for treatment. So just to summarize, lipid disorders are common in children. So now we're talking about our routine screening of everybody. If, of course, there is a premature CAD, obesity, cardiac, or diabetes, they have to be more cautious. Non-HDL cholesterol is the initial agent of choice, which is now available for screening. It can be done non-fasting. If it's high, do a fasting LDL. Two values at 2 weeks and 12 weeks and average them out. Comprehensive assessment for somebody who has a familial hypercholesterolemia in the form of an echo for supravalvular aortic stenosis, in the form of coronary angiography is essential, and statin remain the mainstay. And other thing, you start using ezetimibe as a second-line agent in that perspective. So this was what we want to discuss about lipids. Of course, this spilled over because this is one topic which is extremely extensive, which we are often not able to cover. And this definitely would be an interesting point to really start off with regards to some questions. So I'll see if there are any questions which are there, and we'll take them now. So there are a few questions which are coming up. I think there was some chat questions were there. So Dr. Aradhana was asking about what is the maximum dose of atorvastatin in children with familial hypercholesterolemia. So as I discussed, you can go up to 40 milligrams of atorvastatin and 20 milligrams of rosuvastatin, which can be considered in that situation. Dr. Kishore is talking about, are we routinely doing chylomicron level? No, it is not going to be much help in that perspective. Hyperchylomicronemia and hypertriglyceridemia don't really bother. You can mainly, if the triglyceride levels is more than 1000, generally we are dealing with a hyperchylomicronemia situation. Rarely you can get a chylomicron level, and some people can actually look at the infranatant and the supranatant, and that can distinguish between the two in this situation. Riddhi is asking about the prophylactic role of statin in type 1 diabetes after 40 years of age. So after 40 years of age, every type 1 diabetic should be given a statin therapy in this regards. And otherwise, we're talking about levels which are more than 100. We start thinking about treatment, LDL more than 100. Shaila is asking about, does combined hyperlipidemia cause ITP-like pictures, especially ecchymosis? Yes, if the levels are extremely high, sometimes we can have these features which are there. And is there an association of thalassemia with hypertriglyceridemia? Yes, particularly with liver involvement, sometimes the triglyceride levels can go up. Now, the term child diet, basically what we described was pretty much similar to what was there in terms of child diet, but what we're talking about is a healthy diet overall. In that situation, we're talking about a low amount of intake of energy from the overall fat, decreased amount of saturated and absent trans fat in that perspective. If there are any other questions, we can take them now. So I think, would you please say a few words about options in India for a patient with homozygous FH on maximum dose statin, ezetimibe, failed PCSK9 therapy, not amenable to LDL apheresis or liver transplant? I think this is a very, very challenging condition. Many of us will have patients like this who are not responding to many of these therapies. And probably the only thing in this perspective is to consider a possibility of repeated LDL apheresis in this situation. So again, this is a very, very challenging condition, and I don't really have too much experience beyond going to that level. It's not very easy to manage in that perspective in the situation. So if there are no other questions, we'll probably close at that point of time, and we'd like to thank all of you. What are the dose of omega-3 fatty acid and how to adjust? So omega-3 fatty acid is usually 3 to 5 grams, which is there. The adjustment is mainly based upon the triglyceride levels, which we assess from that perspective. So you measure and try to reduce the triglyceride level below 500. And usually you will not use them alone. You will be combining them with fibrates in that situation. So if there are no questions, I have to thank all of you for patient hearing, because this has been a long webinar now. This is like 90 minutes. So I'd like to thank all of you for patient hearing, and we'll definitely like to have your opinions based upon the feedback. So you will all receive a questionnaire feedback, which you can fill up. And if there are any questions, we can go ahead on that situation. So I'd like to thank all of you, and in this situation, in that perspective. Thank you.